Hi everyone, it's Dr. Jacobs. Today we're going to talk about psychopharmacology for serious mental illness. So the first thing I want to talk about is what is the difference between older antipsychotics and new antipsychotics. So older, typical or first generation antipsychotic medications antagonize dopamine receptors, target positive symptoms of schizophrenia. New atypical or second generation antipsychotic medications do antagonize dopamine receptors, but they're known as serotonin dopamine antagonists. Okay. So that is the one thing that you have to know. Overall, the effectiveness of all antipsychotics are similar, but clozapine, which is a medication, has superior effectiveness when it comes to serious mental illness, according to documentation, according to studies. So that's what you have to know. So if you're sitting here and you're saying, Dr. Jacobs, I've never even heard of the CATIE study, that's okay. The National Institute of Mental Health had something called the Clinical Antipsychotic Trials of Intervention Effectiveness. That's a very long word, right? Clinical Antipsychotic Trials of Intervention Effectiveness. So they broke that down to CATIE. So if you end up working in serious mental illness, you'll hear the words CATIE study. So the CATIE study was a large clinical trial comparing the effectiveness of first generation and second generation antipsychotic medications, which is what we just talked about, right? Almost 3/4 of patients switched from their first medication to a different one because of side effects or failure to adequately control symptoms. Older first generation medications were equally effective and as well tolerated as the second, newer generation medications. The study's findings indicated that on average, newer medications have no substantial advantage over the old medications. However, it's possible that individual patients could respond differently to different medications. Among patients who did not respond to the first-line medications, clozapine was substantially better than all of the other medications in receiving a response. I will include a link on this page for more information about the CATIE study. But basically, people had the same results. So then this question often comes up. Why are many of the same medications used to treat serious mental illness, especially schizophrenia, that were used 15 to 30 years ago? So drug discovery has been really slow in the field of serious mental illness, especially with schizophrenia. This reflects a fundamental lack of biological targets for drug development. It's a challenge for basic science and for pharmaceutical companies. There is some hope that new large genetic studies will shed light on biology, which could lead to new treatments. Clozapine, like I keep saying, remains the most effective and underutilized antipsychotic, although it does have important side effects. In this way, clozapine represents new treatment options for many of those who haven't tried it. I'm not a clozapine representative. Like, this is coming out of lots of different data that I pulled. There are some new treatments in the development for medication and medical devices. For example, TMS, so repetitive transcranial magnetic stimulation for depression is an example of that. So another question, right? Like, can medications used to treat serious mental illness be addicting? Some of the medications that are prescribed for people with serious mental illness can induce physical and psychological dependence. The American Society for Addiction Medicine has a definition for addiction if you need to read that. Benzodiazepines are one example of medications that can be helpful, but can also have some addictive properties to it. The current opiate crisis has been driven in part by overprescribing of addictive medications. Psychostimulants like Adderall and Ritalin can be misused in addictive ways as well. Antidepressants and antipsychotics do not have the same addictive risks. However, all medications have side effects, and it's really important as clinicians that you have a strong understanding of them. So as you go through this module, I have provided breakdowns of different medications. So please take the time to read each one, including the side effects. The fact sheets that are on this course are really easy to read, easy to review. Save them, put them in a folder. because you may end up becoming an expert in those areas with your clients. So this is important as well. What metabolic monitoring is appropriate when patients are taking antipsychotic medication? And are there labs or vital signs to monitor? So you might be sitting here thinking, Dr. Jacobs, I'm a social worker, like I'm not a nurse, I'm not an MD, like why do I have to know this? Well, you could possibly be the communication between your client and their MD, between your client and their prescriber. In addition, 10 years from now, social workers may be prescribing medication. I am not sure where the field will go, but we want to make sure that we are fully round, like well-rounded social workers, and we have all the knowledge if we're working in serious mental illness. So patients that are taking antipsychotic medications are a population that are at increased risk for metabolic problems. What are metabolic problems? Diabetes, hypertension, obesity, kidney issues, liver issues. Monitoring depends on, your client's history, pre-existing conditions, use of medication, all medications that they're taking, their risk factors, their health status. So some of the assessments that your client should make sure that they're having done, not by you, but just in general, are having their pulse taken regularly, their blood pressure, weight, height calculations, their A1C, lipid panel, their CBC, their electrolytes, their TSH, toxicology. Follow-up assessments are really going to be important. So you may be the one that asks, like, is your provider getting these things done for you? They should be done every 6 months and quarterly. And then once they're on a new treatment, a new medication, they should have their follow-up assessments done at 2 months and every 4 months after that. And those assessments should include their fasting blood glucose, their hemoglobin, A1C, and their lipid panel. Your client may say to you, I don't have diabetes. I don't have any issues with my blood work. I don't need to have these things done. And then it's your job as their, as part of their medical team to say, it's really important because you're taking an antipsychotic medication just to make sure that your labs and vital signs look good. And that's the end of our lecture for Psychopharm. Have a good day.